Hello, everyone. Welcome. As we let folks trickle in here, we just want to make sure that you can first of all hear us. So if you have a chat function open, please just give me a quick message in there letting me know that you can see. The other piece is we invite folks to unmute themselves in this particular webinar if you'd like to ask questions. We want to make sure it's very conversational and we can take your questions along the way. So let us know in the chat if you're having any issues with unmuting yourselves and we can address, but otherwise feel free to unmute and interrupt us if you'd like to ask a question. Before we get started today, we actually have a few poll questions for you. So this should appear on your screen and we're going to give you just a couple seconds here to answer. So the first one's up on your screen. Go ahead and answer that one. Only about 50% have voted so far, so if you've got access to a mouse and you're dialing in from your computer, please do answer this one. We'll close in about 5 seconds. Okay, closing this one. Launching our second poll here. Go ahead. Noting here that we've got about 20% rural folks on the line, so welcome to our rural practitioners. And I'll be closing that in 5 seconds. Okay, next question. Closing in 5 seconds. And about 90% of you have read the interim guidance. Next question. Okay, closing in 2 seconds. About half of you have prescribed, so thank you for that. Last question here, and then we'll get started. All right, and closing this poll. Great. All right, so no surprises here that you're tuning into a interior health specific webinar around COVID-19, substance use, and pandemic prescribing. So we have a number of presenters that I'll introduce shortly, but this is Amanda Giesler from the BCCSU, and I'll be your moderator for today. So before we get started here, we wanted to do an acknowledgement about the lands on which we're dialing in from today. So on behalf of my Vancouver colleagues on the line, we would like to respectfully acknowledge the land on which we're calling in from is the traditional territory of the Coast Salish peoples, including the homelands of the Musqueam, Squamish, and Tsleil-Waututh First Nations. And also, given that you are folks in the interior region, we wanted to take this opportunity to recognize the unceded territories in your region, and there are a number of them, and bear with me here, I'm going to acknowledge those as well. So the Okanagan, the Kalkel, Statliam, Tanaha, Shewepum, Inklakatma, and the Kuto nations. Forgive me if I pronounce those incorrectly, but we do want to respectfully acknowledge the lands on which you're calling from today. All right, so here's a quick snapshot of the agenda. So as I opened with at the beginning, we will provide a little bit of a context and background setting to the pandemic prescribing guidelines, but really wanting to keep the majority of this session today case-based, opportunities for discussion, ask us questions, either through the chat or unmuting yourself. We have some cases to share with you, some rural and remote perspectives, so we hope this will be an engaging session for you all today. With that, we have an amazing panel set up. So I'll start off with their introduction. So we're going to hear from Dr. Christy Sutherland, and she's our education physician lead at the BCCSU and a family doctor with the PHS, and provides care to Canada's most vulnerable population in the downtown east side. I should definitely plug that she is Canada's Family Physician of the Year, and she's the medical director of the PHS, leading a team of physicians and nurses. We have two physicians who will be walking through a number of our slides today from Kelowna, Dr. Megan Hill and Dr. Nick Baldwin. So Dr. Hill is a family physician certified with enhanced competence in addiction medicine, a diplomat of ISAM. Dr. Hill works in Kelowna and Kelowna OAT and IOT clinics, the Bridge Withdrawal Management Services for adults and youth, the Outreach Urban Health Clinic, and she's addiction medicine consult at KGH. And then Dr. Nick Baldwin. So Dr. Baldwin is a family physician and medical director for Outreach Urban Health in Kelowna. He also works at Kelowna OAT and IOT Clinic and provides inpatient addiction medicine consultative services at KGH as well. And then we're going to be hearing rural and remote perspective. So Zach Madiashin, a nurse practitioner, who's provided primary health care in the West Kootenays for the past 12 years. 3 years ago, he completed the BCCSU Addiction Fellowship and provided specialized addiction care to the region. He's also a director of the Addiction Nurse Practitioner Fellowship Program. Last but not least, we have Dr. Hunke de Kook, and he's a general practitioner and a member of CCFP, as well as Canadian, American, and International Societies of Addiction Medicine. He's a diplomat of ISAM and the medical lead for Interior Health Authority. So with that, we're in very good hands today and have a number of experts that can walk us through our cases and discussion. So I'm going to hand it over now to Dr. Christy Sutherland to give some opening remarks on the development of this guidance and why we're really here to talk together today. Oh, Christy, we don't hear you. You might be muted.
Oh, there I am. Okay, hello. Yes, I'm delighted to be here. And I really am enjoying these regional webinars because it's so nice to talk with people about their specific context and cases that have come up. So feel free to interrupt and we can have a good chat as we go. I'm supposed to do slides 1 to 11, but since I don't have control of this screen, I can't see when slide 11 is. So just tell me when to stop. I think it's the dosing slide, but I'm not sure. So we're going to talk about risk mitigation. So just thinking about this weighing of risks as we make clinical decisions for each of our patients during COVID and overdose emergencies. We're going to talk about the different pharmacological interventions we have and just sort of help us as clinicians chat through patient needs, circumstances, and preferences. And then so we want to have our patients not have interruption in their OAT, so to continue to facilitate them to access OAT even if they need isolation, and then contingency planning with patients. So, I mean, COVID's here and it's a public health emergency. So we want to help our patients practice physical distancing. I always think whenever I'm developing a program, and this includes our harm reduction programs and my IO program, you know, all of those programs that we've developed at the PHS, I think about my own life and the things that I enjoy in my life and the luxury that I enjoy, especially of safety. Like I think of more and more over the years, I'm so grateful for my own safety, like for a door that locks and water that runs and a safe place to be that has enough food. And I'm especially grateful for that during COVID time. And so I think about that and I sort of use that lens when I'm looking at the life that my patients are living and the risks that they're trying to survive and the choppy waters that they're trying to navigate. And I think, how can I set something up to give them the safety and the things that I enjoy in my life? So we want to employ strategies to ensure safe access to substances to reduce the risk of harms and death that can be associated with destabilization or withdrawal. So let's talk about this pandemic prescribing guidance document. So it's risk mitigation is really what we're talking about. And this was originally written more than a month ago when we were preparing for a surge. And so I was so worried about my patients and COVID coming to the downtown east side. Um, and so I just sort of met with our team and we said, like, what do people need in order to stay at home? And then went through a very fast review process with the ministry and then became a provincial document. And so this is just a tool for you to use in your context as you see fit, and that it's to support patients to self-isolate or maintain physical distance and avoid substance-related harm. So this is not really treatment, but I think, the similar to IOD, IOD often wasn't called treatment, but it really engages people into care, and then I think it counts as treatment for IOD. So we'll see where we end up with this. But I think one of the things we were really worried about was having drug dealers be a vector of COVID in the community because they're not having people line up at the 2 meter intervals and the hand washing and people are touching all their drugs and things like that, or they're storing it in their mouths. Like that's what a lot of the drug dealers do on the corner. They'll keep the baggie in their mouth. So like it's really a high risk COVID moment, I think, for people. And so our goal here was to help them not visit their drug dealer. So the eligibility was very broad on purpose so that each clinician could make the decisions for their context. So really it's anyone who is at risk of COVID or a confirmed COVID positive or someone who is asymptomatic and self-isolating or for patients like if you're waiting for their swab result. It's a history of active substance use, so this is not an opportunity to start drugs that you haven't been using before. So if someone has to be an active substance user, but they don't have to be a daily user, and that's important for consideration when thinking about stimulants, because a lot of our stimulant patients maybe use once or twice a week, and they would still be eligible. And then it's someone who's at risk. So you're worried about them because of withdrawal, of overdose, of cravings, or other harms related to drug use, including COVID transmission from how much they have to engage in the illicit drug market. And then also for thinking about our patients who do sex work or binning or panhandling, all of those risks for COVID that come there. Youth and pregnant people are eligible, but I would call a friend if I was starting a youth or a pregnant person.
Christy, this is slide 11. Sorry, just flagging for you.
Oh, okay, great. How do we develop these? So we looked to the literature and to our clinical experience because there's no research to support this guidance document as a whole. So we just want to be really clear about things that we do that are evidence-based and things that we do that are not. And much of this document is expert consensus, but we drew on the literature from these sort of parallel kind of programs. So I've been doing IO for the past 4 years, and it has been like such a joy to deliver in my practice, I have to say, and really helps people stabilize on oat. Oh, oh, Megan wants me to go to the dosing slide. Okay, so let's go back one then. Uh, and so IOD has really robust literature to support it. So there's a Cochrane review, there's multiple randomized control trials, and then we know it decreases illicit drug use, it decreases mortality, and it increases retention to care. Our IOT program was sort of chugging along, and then patients were often asking me to have dilaudid tablets instead of IOT. They would say they would want 2 DILI-8s instead of injectable treatment. And I thought that was so interesting because they'd be on like 200 milligrams of hydromorphone, and they'd say, oh, actually, I'd prefer 2 dilaudid 8. So it's like 10% of the dose that they were actually taking. And so we developed this program at the PHS and we embedded it in a clinical study. And the TIO patients, we started 60 people on flexible witness dosing that's embedded inside the overdose prevention site. And then it's paired with OAT, and then all the doses were observed by a nurse. So it was so lovely because we could titrate OAT really quickly. Can we go back a slide? Oh, do I have control? No, okay. Uh, this document talks about managed alcohol, which is quite nicely studied, and I'm always very fond of managed alcohol because it's a Canadian intervention, and we know that it decreases crime, it decreases police interactions, it decreases violence, it decreases emerge visits. So it's a really wonderful program, and similar to iode and tiode with managed alcohol, like it's very stressful to be a non-beverage alcohol user, especially if you're homeless, because you're always drinking to avoid seizure and you're always worried that someone's going to steal your alcohol. So in general, if you steal a bottle of Listerine from the Shoppers Drug Mart, you drink the entire thing right away. And then when you start someone on a managed alcohol program and they just have that consistency of a good dose every day and they know they're not going to have a seizure and they can sort of let go of that stress a little bit, and then people naturally decrease their drinking. Nicotine replacement is something that is very familiar to all of us, I think, and that has really good evidence. And it's another example of replacing an illicit substance with the same substance, but a safer formulation. And we also have some unpublished research from Vancouver that shows that illicit hydromorphone use decreased illicit fentanyl use. Okay, and then I'll hand it over to Megan. Oh, you want me to speak about the dosing slide? Okay. So for the opioids, OAT is always the backbone of all of our treatment. So we definitely always want to put OAT first. So methadone, Suboxone, Arcadian. And then actually quite a few of our starts in Vancouver have ended up doing Suboxone microdosing or OAT starts at the same time. You can start your OAT and your pandemic prescribing of the hydromorphone at the same time, on the same day, the same visit. So this is how we did it for Tyote. So it was people who were frequent users. We had fentanyl confirmed on their urines. We knew that they were overdosers. And so we felt quite confident about their tolerance. I had the luxury there that I was observing all of the doses, but we have had 0 overdoses in that program in the past 14 months. So that you can feel safe, but chat with the patient. I find that if they're using a point or two of heroin or fentanyl, whichever they think it is, which 50-50, whatever it actually is, that would be 1 dose. So that let's say they're injecting 3 times a day, I might give them 9 tablets because they use 2 or 3 in each dose. And then I tell them to call frequently to follow up to let us know how they're doing. Some patients prefer M-Eslon and they're injecting that M-Eslon. That's what they like the best. Because a lot of them were using that for many years before they were on OAT. For alcohol and nicotine, we have been just purchasing that for people who are in isolation in our housing. For stimulants, this is the biggest leap from the literature. There's research trials that show it doesn't work for stimulant use disorder. But when we look at that literature, we have to consider that the dosing that was done in those research trials was the same dosing for ADHD. So if you're using like an 8-ball of crystal meth a day, probably that is like, you might as well rub it on your back, you know what I mean? Like it's so tiny for you. They were short trials, around 12 weeks was the average, and that they didn't look at quality of life. And so that I think that that'll be an important thing as we talk with patients over time, because even for my IOT patients, like their quality of life is so dramatically improved. We call it the hipster effect, where like someone who is like homeless and disheveled and angry, so will do their IOT titration and suddenly they come in like a collared shirt and dark jeans, like looking like $1 million. And it's happened that some of my IOT patients get mistaken for staff at my project. So like an outreach worker will come and turn to the patient and be like, "Oh, do I check in with you?" And like the patient is just thrilled. Like what a nice thing to have happened to you when your life has been so chaotic that someone I'd be like, "Oh, that person thought you worked here." It's just is so exciting. And so definitely quality of life is something that I've grown to appreciate more and more as a clinician. And then when I look at research trials, I'm like, even though they're not abstinent from fentanyl, often their urines are still positive from fentanyl. They've gained 20 pounds and they're back at school and they're happy. So that those things are really important. And that's missing. That's not yet done in the stimulant literature. So I think that will be something as clinicians, as we learn more about these interventions, that we can really talk with patients about. And then the benzos, those are the things that actually make me the most nervous in terms of overdose. And in Vancouver, we've definitely seen a shift in the illicit drug market, that we have lots of fake Xanax on the street. And it's probably like, who even knows what's inside it? We certainly don't. And that with Xanax, when you look at the conversion table for like if someone's reports are taking 5 milligrams of Xanax, I don't even know off the top of my head, but it's like super high dosing if you're converting over to diazepam with an idea to do a taper over time. So I would start low and go slow and be very cautious with those benzos, especially if you're co-prescribing them with opioids. And then I would talk with people about being really skeptical about what they're buying on the street, to say like, you're probably not taking the dose that you think you're taking. And that all benzos that we're starting, I'm talking with patients saying like, we're going to get you stabilized. And then over the next 6 months to a year, we'll be tapering you off these medications just because they're so dangerous to be on. And I will turn it over to Megan.
We don't hear you, Megan. You might be muted.
Oh, I'm here. Hi, thanks, Christy. I've just unmuted Nick as well, Dr. Baldwin. We're going to speak together, and we really appreciate your insights, etc., Christy. It's always interesting to hear where things have come from. And to our participants, I think we're also hoping to hear from you and hear some cases that you might have seen. So we'll try to get through things a bit quickly here and have some chats, because we'd love to hear how some of the cases have been going elsewhere. So Nick and I will just kind of cover briefly how we've modified things in Kelowna at the clinic level and the community level, and then we'll touch on some interesting cases. Nick, are you there? I think I unmuted you.
Yeah, no, I'm here. I'm here.
Okay. Do you want to start?
Sure. So yeah, just wanted to speak practically about how some of these guidelines are implemented and what that's been looking like, and talk about some of the kinks that we've been sort of dealing with. So I guess just initially, how do you actually get this prescription to somebody? So depending, obviously, if they're already on isolation or if they're just wanting support with self-isolation, obviously any physician or NP can prescribe them, and we totally recognize that there's going to be not a lot of comfort from general practitioners. Even addiction docs have a lot of cognitive dissonance to get over, I think, in sort of rolling out some of the guidelines. So there's lots of support available, and we have a slide at the end where we can tell you where to reach out. So there's the race line, and you can call the on-call addiction service at Kelowna to get some advice. And soon there'll be I think there's going to be a 24/7 call line specifically for this type of prescribing. In terms of the duration of the prescription, just to clarify the recommendation around 23 days, there's a lot of questions around that. So I think it's primarily to facilitate like a retrospective analysis of how things have gone when the dust settles. So by prescribing 23 days, it would be pretty easy to identify people on PharmaNet reviews who had been getting safe supply or pandemic prescribing prescription. And that obviously doesn't mean they get a 23-day carry. It just means the duration of the prescription is 23 days, and it can be daily dispensed or whatever you think is appropriate. They also recommended just using any prime number like 11 or 13 just for research purposes.
Yeah, and in Kelowna, I think we've been using shorter durations just because I find it's easier to get the patient to come in to follow up. Not that we're cutting them off by any means, but the pharmacy reminds us that they're due for a follow-up. So I've found the shorter prime number prescriptions to be more helpful myself. 23, I think there's a chance we would not follow up as soon. And we've been checking in. I've certainly been checking in with people weekly that I have on a variety of the pandemic prescribing. Yeah, I'll speak to this next slide because I've been following along, and I know we actually have some expert pharmacists on the line here today, so they can feel free to pipe in if I'm butchering it. But there's been a lot of work going on with the various colleges to get us some of these exemptions, and I've been trying to use them when appropriate because I've found they've really helped to open up the care that I can provide for patients. So I just wanted to go over them line by line and emphasize, because I've found many of the pharmacies aren't necessarily aware or are resistant to utilizing these when it's appropriate. So extending prescriptions, I mean, I believe our pharmacists in Kelowna have been able to provide an emergency dose or two on our controlled substances. So they have been doing that for us in the past. That isn't terribly new, but permitting them to transfer prescriptions to other pharmacists. So as most of us probably know, you couldn't transfer methadone between a pharmacy and another. And this has actually been, I've found, really useful when patients are, say, like trying to get out of town to their to isolate with their family or something, and they're halfway through a prescription. So I think it's important that that's something that they're able to access, and I've definitely gotten some pushback on that and had to advocate for patients to have that transferred as opposed to me funding my script pad and finding a way to send a prescription, which brings me to the next point where you can issue verbal orders for these medications as well, which I've found really useful. And I do it as I'm physically writing the prescription on the pad and promise the pharmacist I'll get it to them, because as we know, they get very, very heavily fined if they don't have the appropriate duplicate in their hands when they're audited. But I found the verbal orders to be really nice and flexible because they don't have to wait to receive the original from someone, or in an extenuating circumstance to get a fax of the prescription. So I think that's really helped for much more rapid patient care. I really enjoyed the ability to do that, especially with pharmacists that I know, because they know that I always get my duplicates to them. And then the last one is one that we've been doing a lot of work with here in Kelowna as well, particularly with the pandemic. So permitting deliveries. But whereas before it really was supposed to be a pharmacist that was doing the delivery and the witness of the dosing, whether that was always happening or not, I suppose everybody knows what's been going on in their own communities, but now the pharmacist will not be penalized if their staff or another health practitioner is doing the delivery. And so what we've actually been doing is we've been lucky that we've had nurses that weren't working on the front line and needed work. So we've had nurses that have been able to set up a delivery program for our patients. So that's very COVID specific. So if we need to have someone stay at home and isolate or quarantine, our nurses are able to actually deliver their medications to them. How it's worked in Kelowna, we've only been able to support that Monday, Wednesday, and Friday. So what that means is our patients are having a carry dose every other day and then over the weekend, which isn't ideal, particularly for the patients on Cadian or that are unstable. But it's a change that we've had to make in these times, especially for patients that had a really good reason for not leaving the house. And so it's been actually I found a really useful service. And it's been really helpful that the regulations permit us to do this, and has also, I think, helped keep our patients safe in this context.
I can chime in a little bit there, where I think it's just so interesting. I thought that all of my patients would want take-home dosing all the time, and actually most don't. Most of my patients still want the daily dispensing at the pharmacy because they enjoy going to the pharmacy and or they get kickbacks at the pharmacy. I'm not sure. But the ones who do, it's been really interesting because often they have housing, there's no children in the home, they have a lockbox, and they're working, and they were on daily witness before because they use like cocaine once a week, or they smoke crack a few times a month. So like their urines never were negative for stimulants. And yet I had them on daily witness methadone. But like, I think that we use that urine drug test as a secondary marker for safety. But I think actually it's probably quite safe for them to have take-home dosing of their methadone because they're working, they're housed, they have no children, and they have a lockbox, and they're organized, and they never miss an appointment, and they never miss a dose. So like that's actually, I think, a really good candidate for take-home dosing. So they've been thrilled that they're now able to get take-home dosing. And this is the kind of thing I think about as I'm like unpacking this in my mind and thinking about where we're going as a province, like as prescribers, that I sort of would like to continue that person on take-home dosing, maybe not weekly dispense as I have them now, but I just think it sort of is like shining a light on a lot of things that were, good to consider before maybe COVID even.
That's a really valid point, Christy. I've had almost like 50-50 in terms of experiences with that. For some people, I've been really pleased with how they've done, and it's been a great experience for them, and they feel great. And I'd be pleased to continue with the methadone carries, despite, as you say, the occasional stimulant use. And then other people that it's clear that going to the pharmacy was a good schedule for them, and it was helped them to keep on track, and they really have difficulty regulating their dosing when they're off a schedule like that. So I found it really interesting too, and I hope will change my practice if our college supports it down the road.
Can we take a couple of questions from the chat now, Megan? Would you mind if we address a couple of those to break up some of the content?
Yeah, absolutely. Yeah, are people able to speak themselves, or
I think they prefer to put you wrote them, so I'll just take this one here. So it says, our managed alcohol protocol has been beer and wine, but no liquor. Will this be adequate for patients consuming large amounts of liquor?
We actually have a similar, oh, now I'm having a blank. Nick, I haven't had anyone on vodka, so now I'm trying to remember if we do have any in Kelowna.
Yeah, we do. I don't know if it's still available or not, but it was recently.
Oh, that's right. They pulled it back. That's right. My experience so far has been that cider and beer have held, but I also haven't had patients requesting vodka. So I think it's a valid question because vodka is obviously much stronger. When we made our MAP program, we looked at the equivalencies between the different drinks. So we were looking at, how frequently are you having a shot or a 2.6? If you're having a 2.6 bottle of vodka in a day, you can dose the beer or the cider to be an equivalent alcohol consumption level. And we maxed out at 18 drinks a day as our sort of theoretical max, although I haven't had anyone approach that. So I would think you could dose the beer or cider or sherry or whatever is available to be sufficient to prevent withdrawal and to prevent seizure. The question would be whether the patient would be happy with that, because I think part of keeping them safe and keeping them housed or whatever your goals are is to some extent having alcohol medication that they enjoy. Otherwise, they're going to, I would think, take off and use. Perhaps others have insights too.
Yeah, I kind of question a little bit from a policy perspective why. Is it a policy? And whoever asked that question, was there a specific rationale for a policy to not having hard alcohol? Like, were they worried about excess intoxication, or is it just like a resource limitation? Because if it was a policy, I have a hard time seeing a really compelling rationale for that. I think traditionally MAP is administered in sort of defined discrete doses over defined intervals, and we've had to be a little, unfortunately, flexible with that with pandemic prescribing, because people sometimes are isolating in hotels and they don't have support staff there, 12, 18 hours a day to dispense drinks, and sometimes it's just dropping off a bottle at the start of the day and sort of checking in by phone midday to make sure they're doing okay. But yeah, I just don't, I personally I think it'd be okay to substitute beer or cider in a pinch and accept that you might have a less total daily dose of alcohol, but I would advocate for getting vodka as well, I think, if possible.
Yeah, at our managed alcohol programs here in Vancouver, we have, but one of them we have spirits and wine, and another we have beer, so that patients can pick the thing that they prefer. It's nice if you're doing spirits to provide mix with it so that they don't, so it slows them down a little bit, so that helps people to space it out a bit more. Because that's the nice thing about beer and wine is often it takes a little bit longer to drink.
Great. I have another question here from Dr. David Stahl, and I'm trying to unmute you. David, if you'd like to clarify your question and speak, you can do so now.
Sure. I just found it interesting why we want patients continue using stimulants during COVID, when a lot of my patients, when they use their stimulants, are less disinhibited, more active, tend to go out more, have less potential for actually following kind of social distancing rules and things like that when they're high in their stimulants, especially when it doesn't result in a significant physical withdrawal or, yeah.
Oh, totally. I think that that's such a good point. And that's something I struggle with. Oh, well, because there's the least amount of evidence for it. Absolutely. And that I totally know what you mean, where I have patients who say like, oh, I never use cocaine unless I drink, or I never use opiates unless I use marijuana. Like often things will get paired for people. And that stimulants are, well, benzos too, are very disinhibiting. So if you have a patient who needs isolation and they say, doc, I think I can go without stimulants, I think that that's wonderful if this is the time that they're going to stop using. But I think it depends on each person as you have that chat with them to say, because I think stimulants are harder. I find it hard anyway as a clinician where there's no withdrawal. So for opioids and for alcohol and for benzos, I'm like, oh yeah, of course you're alleviating your withdrawal. But for stimulants, there's not the like alleviation of that physical discomfort that we see when people are using. And so I think it is a different category and it is harder, and it does deserve, I think, a different clinical consideration, just as you're saying.
I think too, my take with all of this, and I, like, full disclosure, have not had a patient that I needed to start on stimulants that I felt there was a compelling reason. And most of the people that I've spoken to do use stimulants, but only occasionally, and they were happy to go without needing me to replace. And so a lot of colleagues have sort of asked, we start these people, how do we end them, or where does it go? And so I think really having a really clearly defined goal for yourself at the beginning of prescribing is important. And so say you were considering someone and then you were finding they're going out more and they're talking to people, or they're not staying in, or they're not staying safe. If they haven't met that goal that you're trying to accomplish with the replacement, then that's a really good case for discontinuing it, or trying to find an alternative therapy. So I think if you're seeing a patient and that seems to be what they do, they're quite social when they're using and they're going out, and even if you were to start them, you would hopefully have follow-up or collateral and be able to assess that you weren't actually meeting your treatment goals at all. So I've found that having really well-defined treatment goals when I'm starting people on any of these is helpful, because honestly, most people have blown away the treatment goals and done really well. And I think if I was starting stimulants, I would want to have really good knowledge that there was an effect.
Yeah, we've had mixed results in Vancouver so far in our practice at our clinic. We had someone who really needed isolation, and we started him on stimulants, and he never left his room for the 2 weeks, and it worked really beautifully. And then we've had other people who we started on stimulants and then seeing them in follow-up, and it hasn't changed their crystal meth use at all. And so I think it's so unstudied that it's hard to predict where it's going. And there's no sort of like clinical advice to be like, oh, if they're a crystal meth user, like that we just don't know enough, and that it is the furthest in left field, I think, of all of this prescribing.
And then, sorry, Lauren, you had your hand raised. Lauren G, if you'd like to ask your question, go ahead and unmute yourself. If not, I see you put your hand back down. So if not, just let me know in the chat. Lauren, are you there? Oh, she said it was a mistake. Okay, we can go ahead with the presentation.
Okay, so maybe I will just touch a bit on how we've made some adaptations to the service delivery of our OAT clinic. Hopefully that's relevant for some people that are prescribing OAT. Like Christy said, it really challenged the dogma of OAT prescribing and made us question like why we do the things we do. Why do we do so many urine drug tests, and do we really need to be so restrictive with take-home doses? And obviously we're balancing the risks of potential harm from medication diversion and misuse, and the point is not to be cavalier, but I think just being conscientious and discerning about balancing the risk of overexposing someone to public and supporting them and trying to self-isolate, but also being safe with prescribing. So in Kelowna at the OAT clinic, and our OAT clinic's pretty massive. I think we have 800 or 900 patients, greater Kelowna area. We've converted to almost entirely virtual care. Say for myself, I'm doing 90% phone or Zoom-based visits. And then we do have a room in our clinic for people that are maybe more chaotic or don't have access to a phone or internet connection. They can come sit in the room. There's a webcam loaded. They can see us in another room, and we just talk to them and figure out what they need. We're giving longer prescriptions for people that are stable, so maybe 2 months for someone who's on the maintenance dose, with the caveat that they know they can call in anytime if they need anything or need to adjust their dose. We've really minimized the amount of urine drug testing we're doing unless it's really going to change our practice management. What else have we done? Yeah, so the sprinkling, so for the most part, people are getting whole capsule sustained release morphine instead of sprinkle if they're able to swallow. Sometimes it's hard to choke down 100 milligram pills, but if they're able to swallow them, it just sort of minimizes congestion in the pharmacy and handling of medications and things like that. And it's been really good. I think we've thinned out the volume of patients we're having by extending prescriptions for stable patients, and then allows us to spend more time with those that are unstable. And so hopefully we can evaluate the processes that are working well and maybe continue them post-COVID.
I'd also say too, I found the telehealth to be really great for a lot of my really stable patients love it. And I think that the GP or the physician billing guidelines do allow for a certain number of telephone follow-ups. So that's something I plan to continue maybe every other visit or so. And then I've also found actually some of the really chaotic patients I can also get a hold of more easily. So that's kind of been cool, because patients that I have had a really hard time talking to in months, suddenly I'm talking to. And so I've actually found the phone follow-ups to be really supportive for patients. And because we've spread out, like we're extremely high volume in Kelowna, it's hard for patients to get appointments and we're often running behind. So because we've spread patients out, I think we have a lot more time, as Nick says, to devote to people, and they can usually get an appointment with, I mean, we offer rapid access so people can get in same day, but it's easier for them to get appointments and do follow-ups on the phone. So much as it makes us nervous titrating people without seeing them, I found that to be a really positive change. And actually, then the only other change, I think, which Christy kind of mentioned too, is the change in carry doses. So I'm doing a lot longer carries for Suboxone, and then I'm prescribing carries for some people that I know to be clinically stable, even if they occasionally use stimulants for methadone. I haven't had to do carries for Cadian, but I would approach it probably similarly to methadone if I had a patient that was a similar level of stability. Unfortunately, that has not been my experience.
I think we can go to the next slide.
And if there's any questions too, like we were hoping to have a really interactive sort of discussion around how things are going in different communities. So it was great to have some chat off script. We kind of touched on Cadian. Again, like if someone was really stable along the manner of being stable on methadone, I approach it the same. And then we recommended not sprinkling. Yeah, so that's been covered.
Yeah, and just to make sure that you blister pack it if you're doing take-home dosing.
Yeah, good idea. There's obviously resources available on BCCSU, so that's a good place to check. Yes, so this is, we'll get into some cases that we've had in Kelowna. And then, again, if time permitting, although we do have our rural colleagues here to talk and our colleagues from Kamloops as well, so we'll try to be a bit quick. So case one.
Megan, there's one question in the chat. Can we get that question before we dive in? Great, and they prefer it by reading. Can you comment on the concern that prescribing hydromorphone might decrease the likelihood of timely OAT for patients presenting with OUD and need to isolate?
My experience so far, and that's definitely a valid concern, and I think there have been patients inquiring about just hydromorphone and not OAT, and case dependent. I mean, there may be reason to prescribe only hydromorph and not OAT if it's a very COVID specific reason. My experience so far has been across the board. Pandemic prescribing has engaged people in care. And I mean, Nick and I do IOT as well, and we found that to be very similar. People we couldn't keep on Cadian and methadone before, now that we've got them on IOT, they're all on their oral OAT. So my experience has been that it's actually been a very good way to get people in and engaging in care. Obviously, though, as you mentioned, it might be a concern that they may not be willing to start, but I haven't had that experience so far. Perhaps others can comment.
Yeah, I can comment. Oh,
go ahead,
Nick. Oh, I'll go. Okay, because I find this. I was really worried about OAT when I started IOT. So that was in 2016. I was worried that my patients would burn the building down, and that they would all start throwing their methadone at me and tell me to go fuck myself, basically. But none of that happened. And the person started an IOT. It did really well, and patients would be like, "Oh, I'm so glad that she's doing so well." And can I go up 10 on my methadone? And so I found that having people on IOT and injectables and short acting doesn't destabilize that person or others on OAT, and that for our IOT and TIOT programs, we can actually titrate our OAT much faster. For those, it was observed dosing, so you really were very sure about the opiate dose the person was getting, and then you can do big leaps of your OAT dosing. And it would be so interesting because we would have so many people who were just not stable on OAT before, like on 30 and then off, and then 30 and then off, and 30 and off. They go on IOT, they get up to 120 of methadone, they taper off their IOT, and then they're just happy on methadone. And it's something that just shifted with them over that 6 months that works so well. And I also think about, like, it's so sad to think about some of my patients in the downtown east side, their family will come to try to find them. And so like some mom will find her son who's like in his 20s, homeless in the downtown east side, and want to take him home with her. And so they would come into my clinic and they'd be like, okay, I found Billy. I'm going to take him home with me to Mission. What can you give us? And I would be like, oh, okay, here we start at 40, here's 40 of methadone. And Billy would be like, it's not enough. And I'd be like, well, I know it's not enough, but we've got to titrate you. And, that parent would sort of look at me and just be like, sort of a bit baffled to be like, well, like, no, like I'm taking him away from the downtown east side. So he's not going to use drugs anymore. Like, can you give him enough drugs so that he doesn't have to go to his drug dealer anymore? Like, why are you only giving me 40 milligrams of methadone? And then I'd sort of be like, that's all I have to give you. And so it's so nice now to be able to supplement someone's OAT start with some short acting so that we don't have that long variable half-life like we do with methadone with our cautious titrations, that we can help them not also use illicit drugs during their OAT titration.
Yeah, that's that's sort of what I was going to say as well, Chris. I think if anything, it's facilitated me starting OAT because a lot of people are so unsatisfied with the initial starting doses of sustained release morphine and methadone that they don't adhere to the program. And I've had some success early on being able to titrating and people adhering to their OAT and titrating up on it because they're engaged in the program and they're more comfortable with the addition of hydromorphone. And I think people who don't want to, are not ready or don't want to get treatment, I don't think the availability of hydromorphone is going to be a deterrent to OAT. I think they probably wouldn't have wanted OAT whether hydromorphone was there or not if they don't want it.
This is a great segue into case one, actually. Certainly, though, if there's any other questions, happy to address. But let's quickly cover case one because it's actually on this topic. So this is a patient that I've actually known for about 5-6 years, but in and out of care, on off methadone all the time. Tried Suboxone, wasn't a fan because couldn't take it regularly enough. And she called in because she was pregnant and she was staying at the women's shelter. Now in Kelowna, all of the shelters across the board closed their doors during COVID and said everybody that lives here needs to stay in, and if they leave, they'll lose their bed. And so this was the case for this particular patient. So this started out as a very straightforward case for pandemic prescribing. So it's a pregnant patient who's dependent on fentanyl, not on OAT. And if she leaves her shelter at all for any reason, she will lose her bed. So if you want to go to the next slide, that's a pretty much slam dunk for these guidelines. So she was started on methadone and then hydromorphone, 6 tabs dispensed daily, and she is doing great is the follow-up. So we've actually just got off the phone with her before this telemeeting thing. Yeah, she's been gotten up on her methadone, and this is someone again that I've had trouble getting in and getting to take regular dosing. I mean, some of that probably helps that the pharmacy is delivering and she's in a shelter. So yeah, really great case, really obvious benefit from it. Pregnancy, she's engaging in pregnancy care. She's not using heroin or fentanyl during her pregnancy. She's using hydromorph and methadone. And as of today, she's at 80 milligrams of methadone, and she's down to 4 tabs a day of hydromorph. So our very clear goal is to go up on the methadone and to go down on the hydromorph to get her off. So the twist to this case that was so straightforward when I wrote these slides, actually go to the next slide. I think that just talks about how successful and cheerful everything was. So the twist is that the shelters have started to open their doors now and people can come and go. So the question today to me was, this person is now no longer at risk of losing their bed or their housing, and they're not someone that specifically has COVID or has COVID symptoms. So do I continue with the hydromorphone prescribing? And the shelter staff were asking if that should be continued as they were concerned she was going to go out and use fentanyl. So I don't have the answer to that. My assessment today is that she remains someone that's at extremely high risk of a variety of negative outcomes. I think given the pregnancy, it's better if she uses hydromorph than fentanyl. I do think there's still a risk of losing the housing if she goes out and becomes quite chaotic with illicit fentanyl use. So I have continued the hydromorphone obviously as a long-term taper and the titration of methadone. So that was a sort of question where we kind of approached the line of where is it COVID pandemic prescribing and where is it more of a safe supply. So that was kind of an interesting case that is ongoing.
Yeah, I can comment on that, Megan, because we have had similar discussions in my clinical team where at first we were only going to prescribe for people while they were in isolation. But then I always think interventions are better when they're open-ended. Like when we look at IOT, there's actually really robust evidence to show us that open-ended intervention is much better for people, and people do very poorly when you cut them off at a certain end date. And so I think about this pandemic prescribing in that same way. And then I also think about that we are going to have waves of COVID. Like we've avoided this surge that we were so worried about, and we haven't had our ICUs full. Like we're not having the like Ontario and Quebec, what's going on there, and so we're very lucky. But that we might have a surge in the fall, or that we think in the downtown east side, like people are not doing physical distancing, and so even just a few cases might lead to a surge in the downtown east side, even if the rest of BC has flattened the curve. So we're not starting and stopping our pandemic prescribing. We're just starting people and monitoring them. And then in our minds, it's going to be a year, 18 months that we sort these things out.
Cool. That's good insight, Christy. Thanks. Because I think we're all very questionable, and our poor patients too, I think, are struggling because we're saying, I don't know what it will look like in the future, and we can't give you any long-term info. So it's definitely difficult. Yeah.
Especially when someone's improved and that you can document that they've improved.
Yeah. Yeah, so I think this case was relatively straightforward, but it kind of got interesting when it was less of an urgency around housing. Let's go to case 2. I just want to remember which case it was because we should probably skip a few of these so that we have time for our rural colleague.
There's a question here that's related to this case. So this one's for Christy. Christy, we know it says here we know that 30 to 40 milligrams of methadone is not enough. Why does BC use such a cautious induction?
Yeah, we're just updating the opiate use disorder guidelines now. So happy to hear lovely different opinions about that. You know, it's something I've been really thoughtful about because we know that there's increased mortality during the methadone induction time. And that's sometimes thought to be because methadone has such a long and variable half-life. You don't want to overshoot like that 30, 30, 30 dead kind of thing that we have heard a lot, but that others speculate that the reason people die is that they're so underdosed that they're actually using tons of benzos and fentanyl trying to alleviate withdrawal. And if we just gave them the dose of methadone that they said that they wanted, that they would actually be much better. And then I think our risk calculation has to change over time. Like 10 years ago, I started everyone at 30 and I waited 5 days before I went up on their dose. I was very cautious, but it was in a heroin context and we were not having these overdoses. And so the patients were safer. So in that balance of risks, I don't know if it was right to do that at that time, but that's what I felt was the less risky thing. And then with the overdose crisis, we now start at 40 in the downtown east side and we go up 10 every 3 days. And then now with COVID, another risk to sort of add into our calculator, I think that sort of calls us to change again how we titrate our methadone because the balance of risk has changed again. So this is definitely something that we're talking about right now with the update for the opiate use disorder guidelines. But the biggest challenge is the variable half-life.
David Stahl actually asked the question. I came from Saskatchewan, and Brian Fern probably spearheaded use 30, 30, 30, 40, 50, 60, and then we adjusted every 5 days up 10 from 60. And we've literally done thousands of inductions that way, and I can count on one hand the amount of patients we've had significant problems with doing that. So that's why I asked.
Totally.
BC,
yeah, I think that's such a good point, and I think it's so interesting. I think it speaks to that there's not good literature that guides the decision when every province has a different formula. Like when you look at Newfoundland and Nova Scotia, like everyone has a different way that they tinker, and so I think that tells us that that we're not basing it on like robust literature to say like, oh, this is definitely the safest thing. So I am very motivated for it to go faster for sure. And but that's by the committee decision for the opiate use disorder guideline update. But send me an email and then I can forward it to the committee and I can say another person and then you can speak to your experience in Saskatchewan and that would be wonderful.
Yeah, exactly. It sort of speaks back to the dogma of opiate agonist therapy, and it's really the absence of sound like published data that it's safer to go faster. But it's an interesting ethical conundrum because we're so worried about harming our patients that we'd rather indirectly harm them by underdosing them a very small chance of directly harming them by overdosing them with methadone. It's just an interesting piece of psychology, I guess, the way we prescribe like that.
Oh, totally. Like who owns the risk? Like we're very risk averse with prescribing often, but it downloads the risk onto the patient. And I also think like if we look at like appendectomies, I don't know much about appendectomies, but there's probably not the variety province to province of how to take out an appendix as there is for OAT titrations.
Yeah, great question. I might also say too, just further to the Acadian and then this COVID prescribing, we've been, with people being on hydromorphone and Acadian simultaneously, you're in a position where you can actually bump the hydromorph up a little more quickly if they're demonstrating a tolerance with the, you can bump the Acadian up more quickly if you're demonstrating a tolerance with the hydromorphone, as long as there's regular check-ins and people around. So I found that actually really useful in that way as well. All right, I want to be mindful of the time here. Oh, go ahead, Nick.
Yeah, should we just skip ahead to Zach's case, maybe?
Yeah, let's do that.
Oh, just noting that I think we do have an hour and a half for this session.
Yeah, and we've used an hour. Yeah, we want to give Zach a chance to talk because I think the rural perspective is super valuable. And, you know, I've done some rural work, but I'm certainly not practicing rurally in Kelowna, so.
All right, over to you, Zach, if you can unmute yourself. Nope, not coming through.
There we go.
There we go.
Yay. All right, thanks for inviting me. So I'm here in somewhat sunny Nelson, BC. And I should have made a slide on some of these rural points, but maybe I'll just preface. Outside of Vancouver and outside of Kamloops, Kelowna, Vernon, many of us practice in smaller communities. And so it's a challenge for patients, I'm sure, to even find a prescriber in many of these places. In the Kootenay boundary, we have, just to brag a little bit, we have a little community of practice amongst the OAT clinics. So a couple dozen docs, NPs, nurses, social workers, pharmacists meet once a quarter to sort of wrap through practice issues. We have a little journal club, and so that's been quite useful the last couple of years. And so we did meet as a group when these guidelines dropped, and I think I'm equating it to the 5 stages of loss or grief. I think you know, that eventually leads to acceptance, but there's I think for a lot of us there was, you know, sometimes quickly, sometimes not so quickly, getting to the point that yes, this is a reasonable thing to do, and you know, we're not going to break the world by starting to engage in this practice in these exceptional situation we find ourselves. And so it does bring some other issues to front of mind. So, and a lot of them are the same as they were for OAT prescribing. You know, for the folks that live right in a community of like Nelson or Trail or Castlegar, and they're a couple of blocks from the pharmacy and their clinic, then, you know, no big deal. But for folks that are 30, 60 plus minutes away without reliable transportation, we've always had to make tough calls with even inducting people on OAT and, you know, waiving those guidelines around, you know, when to implement carries. People, you know, either don't get OAT or you need to, you know, entertain carries right off the bat, or pharmacies only open, you know, 5 days or less a week. So, so that's sort of the rubric we're working with. And so this case is an amalgam of a couple of patients that myself and my colleagues have been dealing with, and just for consideration. So we've got a patient who's 38-year-old male with 10-year history of opioid and stimulant use, who lives 45 minutes outside of town. He's trialed methadone and bupe for a couple of times each. You know, has maybe made it therapeutic once out of those 4 times, but typically falls off as he has difficulty making appointments and and pharmacy pickups, and misses enough days that he's back to zero again. So currently he's hitchhiking into town to solicit and procure the opioids and stimulants he needs, and currently using half a gram fentanyl and 2 to 3 points of crystal meth a day. So so he's heard of pandemic prescribing, and I would say it spread more quickly through the people who use drugs community than it did through the prescribers, I would say. The grapevine is far more efficient in knowing that these guidelines exist, and so I'm impressed by the number of people coming to me. So this patient has heard of pandemic prescribing and an interest in getting on hydromorphone and dextroamphetamine, preferably with weekly dispensation, so he doesn't have to go into town so often. And myself, my clinic and most of my colleagues have a 1 day a week OAT practice, so that's sort of the limit that we can actually see people or have time set aside to do a virtual visit. And most communities have minimal to no outreach supports. So yeah, so what are the considerations we would have to safely dispense these medications? And so I'm hearing different things from our urban colleagues that of a varying pickup and carry schedule. And so yeah, I think it's been challenging, even for people in town. I've made some variations. Some people who are close to the pharmacy, and it seems like they're just going to go from their home to the pharmacy, and they're okay with dailies, and then it's this big calculus of limiting exposure with the public and encouraging isolation versus the safety of not handing out these big bottles of hydromorphone and dextroamphetamine. So I would say some of the considerations for this fictional, not fictional patient is one guy who fits this, who we've seen is actually quite seemingly stable and reliable, and an outreach nurse actually did live close to his way, and so actually could hand deliver twice weekly drop-off schedule because getting into town was a challenge, and check on him. And somebody else, I had to make the call to do weekly dispensations from the pharmacy, and held my nose a little bit with it, but after 2 weeks he hasn't died, and by all reports seems to be doing reasonably okay and isolating reasonably well. And for somebody who we had a high degree of concern about handing out anything more than twice or twice a week dispensations, I'm not sure what we would do. So I don't know all the answers on how we manage some of these complex rural patients who live far out of town, but would benefit from this prescription program for isolation. So maybe I'll pause there for thoughts, or I don't know if there's any rural colleagues, or certainly Meg and Nick or Christy, if you have thoughts on how you approach something similar to this.
I can chime in. I had similar cases where someone, because I think like if you build it, they will come, kind of thing. And then I remember doing the IOT guidance document, and we had this very kind of scenario where physicians were worried that people would come for IOT and decline OAT. And then that was sort of thought of as a reason to not give IOT if they hadn't had an adequate trial of OAT, but maybe they had a trial in the 80s or something like that. But I would just start them, and then over time they start OAT. Because I think we hadn't been seeing them in medicine before. because they weren't interested in what we had to offer. So really it was like the nurses on that committee, I remember, who were quite passionate about this issue, because they were saying, we see all these people all the time on our outreach. They are not coming to see you physicians because they don't want what you have. And so now that we're offering something different, we'll see people who perhaps weren't engaged before.
Thanks, Christy, and definitely agree on that point. That yeah, that's the second point posed here around if we should be really pushing the traditional OAT first or acquiescing and giving this other. And I, speaking personally, I've definitely gotten to the point of realizing that yeah, there's a reason why they're not on methadone, Suboxone, Arcadian, and that reason is varied, but if the low-hanging fruit is hydromorphone, and that's going to stabilize their use and exposure to contaminated drug supply, and also, of course, isolate them, then it's a reasonable play. How are you approaching carries or less frequent dispensations?
I think it's with safety in mind, like, because we want someone to have safe storage, and we want no children to be poisoned by the drugs that we're giving as take-home dosing. And we want someone to be able to be organized enough to spread out their medications to match the dispensing. So if someone is quite chaotic, and I was worried about them going through all their medications at once, I might just have like a good discussion and be like, do you think if I give you a week at once, is it gonna last a week? Like, what do you think? And sometimes people are quite insightful. They'll be like, oh, no, you're right. I'll just go use it all at once. That's how I am. And so then you can talk about different sort of logistics for them. But I think really the lens of safety is the one that we want, and thinking about public safety and that individual safety in the context of an overdose crisis and COVID. So it's a lot of things to consider for each case. To document well, that's always my tip.
Dr. Engelbrecht is on the line and had a question. Did you want to go ahead, Roland?
Oh, I just wanted to comment on the carries, and I think it's just the same as what Christy said. I think we individualize it, and it depends on if they can store it safely. So for my patients who are homeless, I haven't been giving carries, but if they got stable housing, they got safe place to store it, then Suboxone carries, I've been easily giving that out. And methadone, I've been giving some carries, but not as much as for Suboxone. So it just depends on the individual, I think.
Christy, I just wanted to, sorry, go ahead.
No, go ahead, Nick.
Well, I was just going to, I think this case highlights a little bit that sometimes there's a blurred line, and I want to put this out to the panelists to sort of help delineate a little bit the difference between pandemic prescribing with the explicit, direction of keeping people safe and helping them self-isolate. But then also this kind of speaks to the larger issue of addressing a toxic drug supply with providing something safer. And so I think a lot of people are getting a little bit hung up on the blurred lines there between, like, okay, what if someone's coming in not exactly with the intent of self-isolating or needing to be on quarantine, just requesting hydromorphone as a replacement for their toxic fentanyl that they're using, and sort of how do we respond to that? Like, are we ready to roll that out and scale that sort of thing?
That's a great point, and it's something that I think we've grappled with locally here in the Kootenays, and it is a lens that I'm putting everything through. I mean, I think many will agree, that safe supply is an idea whose time has probably come. Is this it? And the time and this is the format, is a matter of discussion. But my read of the guidelines is that this is this dual, public health emergency risk mitigation. And so I want to hear from my, interaction with the patient, how is my intervention going to assist them to isolate more and socialize less? And I'm going to need to hear some coherent, idea that my intervention is going to assist with that. And I have had a couple of people say, no, actually, I think if I get this, I'm going to hang out with my friends more, and I was like, that's the exact opposite answer I was hoping for. So I actually said, I don't think I can offer this to you. This is meant to help you isolate and such.
Yeah. You know, I was getting spicy about this issue today because I think that it is the job of our government to keep our population safe. And that criminalizing people who use drugs and pushing prohibition and having organized crime making billions of dollars tax free in an unregulated market where they're at the high school trying to initiate people into drug use is just the worst system possible. And that here is this very awkward, rammed through medicine solution that has physicians taking on this burden of hours of work, prescribing in a way that is not evidence-based, and a massive amount of time, and also like it jeopardizes our clinical relationship with our patients. And like, why am I spending my time like doling out hydromorphones when I should be optimizing blood pressure and like taking care of complex diabetes and like, I didn't really go to med school to deal out dilaudid. And so I find it very frustrating. And I had a very frustrating moment today. I was on a call with Health Canada and I was like, listen, like, why are you making my life harder? And why are you causing the death of Canadians with our drug policies? That there should be a regulated market where it's safe for people to go and purchase drugs that they use for fun that has nothing to do with physicians. Physicians should not be the gatekeeper to this, but we're sort of forced to because of the overdose crisis and because of COVID, that we're the gatekeepers to opioids. And so we're the supply chain of opiates for people who are opiate users. And I think that it's just unfair to ask physicians to take on this burden. And then that's what leads to these crunchy moments of physicians being like, well, I would like to give you methadone. That's the thing that's evidence-based that I know reduces your mortality. But I would like you to not die right now from COVID and from fentanyl. So where does that leave us? And so I just, I was getting all hot under the collar today and I was like, I'm going to email the CMA. And like, I just had all these ideas about what I was going to do about this, but it just is so frustrating because I find politicians will come and tour the Downton East Side and they'll be like, oh, you guys are doing amazing work. What can we do to support you? And I'll be like, well, you could end the war on drugs because that would really make my job a lot easier. So I think that that's this crunchy nature here, that this is a medical solution to a problem that was caused by our own government and our own criminal justice system that is being magnified by a pandemic. So like, what a recipe for uncomfortable physicians, uncomfortable patients, and tension.
Yeah, and to second that, Christy, I think a lot of our hesitation around around safe supply, not pandemic prescribing, is just like I don't know about other people on this call, but I just don't have the capacity to take on hundreds of hydromorphone patients.
Well, and it's a waste of your expertise, I think. Like for
Yeah.
me, the term safe supply means the government should be prescribing it. I don't think safe supply comes from physicians in our prescription pads. I think that it's like, it's not the liquor store, but it's something like a place where you go and you purchase it and there's a nurse there and there's a screening process and you're followed and then maybe it's paired with medicine, but that it shouldn't be, physicians should not be the gatekeeper for recreational drugs.
Getting back, Ben Wall here. Getting back to the case, I was wondering if BC Housing would be able to house some of these people in rural situations, so they would be able to self-isolate and have ready access to the medication, without having to have a week at a time type thing.
Yeah, that's such great thinking. I know in Vancouver, we've been using empty hotels, and then we've done scale up, not we, but BC Housing has been scaling up across BC the modular housing units, which have been really wonderful. At PHS, we have several modular buildings. They go up within 90 days from sort of breaking the ground to being tenanted, and they're a really like lovely option for people. So I think housing is also such an important part of this conversation.
Yeah, that's such an important point, Ben. And I think one of the things that's been very frustrating for those of us in the interior and elsewhere and in small towns is how slow the housing has moved and how slow the reaction has been to getting housing. And I mean, I commented earlier on the shelters closing their doors. You can imagine what chaos that put us into trying to get people housed when the shelters weren't taking anyone in. And it's been a slow and painful process trying to get any housing for anyone in Kelowna. I'm sure that's similar in our with our rural colleagues.
Yeah, I'm sure many communities have had some sort of solution to this, locally, and the Tri-City West Kootenay region, there's an idea for campgrounds and using hotels, and so that's what's been pursued in Nelson, with initially poor uptake, but I think the community is realizing that it's not half bad, and honestly, pandemic prescribing has become a bit of a carrot, I think, to move into these better isolated, better living situations, and so I think all needs are being met.
Do any of the participants have any interesting cases to bring up? I know we're a bit time limited, but really interested to hear if anyone's had a good case.
Maybe while folks are thinking of their questions, Megan, maybe Hanka, would you mind giving some remarks from the health authority in terms of planning and the health authority? We can't hear you, Hanka. You might be muted.
He's unmuted now.
Okay, hi. Yeah, I just would like to thank Amanda and Lisa for putting all of this together, and Christy, Megan, Nick, and Zach, thank you so much for the cases. So yeah, that being said, not all the services will look like the Kelowna model. We do appreciate that need and capacity vary greatly across the region. So we are working with a number of communities to support implementation of the managed alcohol program. We are working on a regional pre-printed order to support the managed alcohol program in hospitals. Ideally, what we would like to see is like the primary care providers supporting the recommendations in the document as much as possible. Reach out to the addiction medicine consult teams for guidance if needed. But every community is different. Please reach out to me directly to help and support implementing these guidelines into your community. I'm happy to assist and try to come up with an individualized approach for your community.
Great, thanks. Megan, I think, do you want to take over this slide? There's no questions currently from folks.
I think we've discussed a lot of this. If we think about the sort of long term, and that's what many of our patients are asking, like, you're prescribing this for me now, how long is it going to go? And Christy definitely spoke to this as well. I know in Kelowna, and we didn't actually get a chance much to chat about how the the alcohol provision program is looking like, what it's looking like here. But I know our hope, because it is such an evidence-based program, is to continue it long-term outside of the pandemic. So some of our patients that were receiving COVID-specific alcohol prescribing have been discontinued when their shelters open back up again. And we have not actually had any NBA users on our program as of yet, but we are anticipating a long-term rollout of that, of the alcohol, and we are really hoping to engage with rural communities to support MAPS there as well. And again, like, it's always so different when you're in a rural community compared to like Kelowna or Vancouver or Preston or what have you. So I really do hope to engage with colleagues there to know how it's going to be different for them in terms of a rollout. So long term, definitely the managed alcohol, hopefully some guidance around opioid supply. And I do think tapering benzos is always an important thing, starting people on benzo tapers and supporting them. And that's always as we know, a very, very long-term prescription relationship. Mine seem to take on average a year. So yeah, in terms of long-term, I think it's been helpful to have Christy here to give us some perspective on that.
Dr. Farron, did you want to ask your question to the group? I can unmute you here. Oh, we might have lost her. I think she just had a comment here in the comment box in Kamloops using new option of TIA over the last couple of months to bridge patients. Lots of interest, 40-ish patients, and a wait list.
Amazing.
Dr. Whistle is just commenting as well that there are many patients from out of province. Let us know, Peter, if you'd like to be unmuted and to talk about that a little bit more. Oh, go ahead, Peter, if you'd like to discuss out of province.
Oh, hi. So really the question was, what about coverage for patients who are out of province? We get a lot of patients from Quebec, and it's really hard to prescribe for them because they can't afford Suboxone.
So are these like temporary labor workers who are not planning to apply for MSP?
Exactly.
Yeah.
I mean, they can't speak English.
Yeah. Yeah, that's a challenge for sure.
But is there a way of addressing that challenge at the moment? Because they're coming now.
I think that would be a good question to bring to Interior Health and put that to them, because if they're going to be in our area and they're going to be contributing to our food supply, there needs to be, and actually I've heard there's been a lot of concerns around migrant workers and farm workers and their potential safety for themselves, as well as coverage for medications. Yeah, I don't have a good solution to that, but I think it's something for the health authority to take a look at. I think we do have some health authority folks on the line here.
Yeah, and wondering if Hanka, that's something that you can connect with Peter after this webinar.
Yeah, will do.
Great, sorry, go ahead with this slide. There's no further questions.
I think I've finished the slide unless anyone has anything to say.
Well, I just will add that I know a lot of people have some reticence about starting to prescribe short-acting opiates and stimulants for people with use disorders, with the concern being once we open the floodgates, how do we, if things don't go well, if there ends up being bad outcomes, it's going to be very difficult to, as someone has put the genie back in the bottle, and how do we change things? And I think it's just a matter of looking at setting some measurable outcome goals with your patient and assessing clinical stability like you would treating any other use disorder. And if it's very clear that someone's not benefiting from the Dilaudid tablets that they're being prescribed, there's no evidence of stability, there's no change in drug tests, they're not self-isolating, then you have the conversation about, hey, this hasn't been an effective intervention, and here are some other options available for you, and just being flexible. But just trying to set some goals with your patient and define parameters that you might be able to track to assure yourself that what you're doing is actually benefiting them.
Yeah, I think urine testing over time will be very helpful. If you see that fentanyl extinguish, then you can feel good that they're engaging in the illicit drug market much less.
It will be really nice when we can urine test again.
Yeah, we've started doing a little bit of point of care again. We're not sending it to the lab, but we're doing a few more point of care testing now as we get our groove with the telemedicine.
Are you having them come in, Christy? How are you doing that?
Yeah, for our telemedicine, the patients come into the clinic and we have a little stand set up with a phone, or some of the clinics have a computer and the nurse is there in PPE and they FaceTime with the physician.
Oh, so they can do a urine. Okay, that makes sense. I guess, Nick, I think you spoke to the resources a little bit before, but we are the Kelowna Addiction Consult team loves to talk to community colleagues, and we were hoping to start a map on the wall from all the places we've heard from. So we are happy to take your calls. We're bullet 4 there.
Great. Any final questions? Go ahead and raise your hand or unmute your mic or let us know in the chat. We've got a couple minutes here for a last question or two.
Ben Wall here. Just wondering, are there any instances where we're reaching out to capture this community at risk, or because it sounds like an awful lot of what's happening is people are showing up on their own, and when they show up, then we deal with it. But and if so, how do we make that work in a practical sense?
So far for myself anyway, it's mostly been patients coming and advocating for themselves, or support workers coming and bringing them to our attention. I know in Vancouver that the word tends to get around quickly. It sounds like that's what's happening out in Nelson too. I haven't seen as many people in Kelowna with awareness of these programs, so it doesn't seem to be as prominent that people are coming in themselves. So it's a good question, and I think it's hard for us to know how to promote it because a lot of it is they come to medical attention for COVID reasons, and then we implement the prescribing.
Any last questions from the group? Go ahead and unmute yourself and ask away. All right, hearing none then. Megan, did you want to make any last final remarks here before we sign off?
No, I appreciate the opportunity, and it's great to hear what's happening in other communities. And actually, I was going to say, Zach, we are always interested to get insights from rural colleagues because we certainly see patients that we send back out to rural communities. And well, we manage Beaverdale, for example. We keep them a steady supply of Suboxone via one patient. So we're always interested in your insights and advice on how you adapt things rurally. So it's very interesting for me.
Great. A big thank you, everyone. A big thank you, especially to our panelists today for making the time and for folks for sending in your questions. As always, please reach out if you continue to have questions or would like one-to-one follow-up, and we'd be happy to answer and connect you appropriately. So with that, we'll say thank you and wrap up, and have a great evening. Bye, everyone.
Thanks, everyone.
Everyone.